Rehabilitation is taking a person with any disability or impairment to their highest level of functioning. And it's different for every individual.
These are the people who make sure that you can take a shower, make sure that you can actually put toothpaste on your toothbrush. I was beginning to lose function in my hands, and in particular strength, but also in coordination and in feel.
We had George come into our clinic, and he was familiar to me. Worked with him in the past. A lot of our patients do that. They'll come in, we'll kind of get some fine-tuning of home programs, and then they'll return, and then we can again assess and see where they're at. And so when we saw him, I was able to do a grip strength to see how his hands are doing. He was given, sequenced exercises to follow with his hands, and he knows those very well now and does them often. He was also given just general activities that would improve his fine motor coordination and dexterity.
There's a growing body of research now to say that individuals who exercise with MS have better outcomes. We're great at dealing with spasticity management by stretching, doing weight-bearing activities. Fatigue management is another symptom that we're involved in. And contrary to some people's belief is that doing exercise to work on endurance is not going to cause more fatigue if it's done properly. We're always working within an individual's limits and we're respectful of their fatigue, but deconditioning really contributes to fatigue. So we're really looking at getting someone to their highest level of fitness so that they can manage their fatigue symptom easier.
Exercises that strengthen his core, that makes him sit up easier, that helps him push his wheelchair easier. Those are important because his fatigue doesn't happen as quickly.
By the time I got into therapy, PT, there was not much function left in the lower body at all, and it was just almost, well, it's a paraplegic situation, and there really wasn't anything she could do with that. So she just wisely went on with what we had, and mobility and strength and maintaining the wheelchair and operating the wheelchair and staying independent. What's important to my independence is my upper body strength, because I don't use the lower body. I try to maintain the lower back, the shoulders, the arms, the wrists, the hands. You try to keep that as strong as possible because that's what you're using for mobility, but you do need to keep moving.
Not being able to drive is a huge loss of independence. So we'll work on strategies and skills in physical therapy for the motor control of what you need to drive a car. OT and speech will work on cognitive and processing speed and those cognitive activities that you need to be able to drive a car. We have resources in the community to have retraining for driving or special adaptations if physically there's something that doesn't allow them to drive.
It may be something as simple as a brace for your ankle that we can do inconspicuously to hide under pants or in your shoe. But some of the bigger items, just think of it as exactly that, empowering. I can get out and do something for myself, by myself. I don't have to have somebody else do it for me, and I don't have to get hurt or struggle to do it in the process.
The physical therapists are the people that work on mobility. We look at leg strength, core strength. We also look at, do you need particular pieces of equipment? Do you need some assistive devices? We also are the ones that will do wheelchair prescriptions. So we get what an individual needs in order to stay mobile or be mobile in their environment. When someone arrives for their rehab session, the first thing that I do is I check in with them to make sure that it's the status quo. I'll ask them if they're having any pain. I'll ask them if their symptoms have changed. Make sure that everything is going good. A lot of times somebody will come in with fatigue, and that will determine what we're going to do in a session.
Physical therapy will start out with stretching. Pulling the legs up, stretching them out, pushing them to their limits, holding and pushing farther, and stretching the body, where she gives me the stretches. And then she has me do the stretches. After that, we move into weights and balance, body motions, turning, that type of thing is what we actually do in physical therapy.
I want to figure out why this person's having difficulty, and a lot of times they may even say to me, my hand's just weak, I drop things. But then we'll do an assessment, perhaps do a peg test or the grip test and figure out exactly what's going on. The reason they may be having difficulty could be that they have spasticity, that they have weakness, that they have difficulty with in-hand manipulating skills and dexterity. They may be having sensory problems that it's making difficult for them to maintain a grip on things. So once we've kind of figured that out, we're going to custom make a home program for them, exercises that are appropriate to improve what might be giving them difficulty.
Occupational therapy traditionally had been thought of as get into the workforce or stay into the workforce. And it has really grown, the discipline has really grown, and it really includes whatever your occupation might be, and that might be homemaker, that might be mother, that might be caregiver. And so it's a much broader term. It's not just employment, although that can be a piece of it, but it's really activities of daily living that keep you functioning.
So my job is primarily to help people with MS improve their swallowing function, voice, speech, language, and cognitive issues related to their diagnosis. What I see, or what we see in patients with MS, is having a lower volume in their voice, so you just don't have the respiratory support to be able to project your voice. Usually you can't project your voice when you want to say something across the room or you're in an emergency situation. Also, it's common with dysarthria, patients who have dysarthria, to have maybe a slurred quality to their speech, so the precision of their articulation isn't as good as it was previously. When you have MS and you start to have speech issues, you never really before had to think about how you're speaking. It just came out and it was clear, but now you have to think about how you're speaking, what you're saying, following along with the conversation. So it does sometimes take a lot of practice to be able to think about all those things at one time. There can be really serious consequences of having difficulty swallowing. Our main concern is that food and liquid is not going into your lungs. Our goal is to try to improve skills that are weaker, areas that are weaker, but also to compensate for any of those changes. So for like change in memory, we use a lot of training people to use iPhones, smartphones, tablets, to log information, to plan for things that are going to happen in the future. For word finding, I teach people strategies and tricks to help organize the way that you come up with those words so that you can come up with them a little bit quicker, and also to decrease frustration when they do have those word finding issues.
Mood is always addressed in rehab. Primarily, we want to make sure that a patient is relatively upbeat and can take part in their therapy and understands all these things. And when we talk about mood and cognition go very close hand in hand, so we're addressing both of them at the same time, because one can affect the other and vice versa. In terms of cognitive rehabilitation, most of that is done by the occupational and speech therapists, and the reason that's helpful is because they're doing it in vivo. They're doing it in a natural setting, perhaps, where doing it on paper and pencil testing is really not always generalizable to the real world.
Working on cognitive skills, it's not only important to get the therapy team to work together, but it's really important to have family members involved so that they can help carry over the strategies that we're teaching, and those strategies are specific to that person. It also helps with accountability, because if what we're doing in treatment, helping improve memory and attention, it's great if you can do it within the session, but it's really the most important thing is to use those strategies, techniques in your real life.
This summer, with the program that my physical therapist gave me, I'm about 40 minutes in the pool every morning, and then I try to get in the pool again in the evening. But there again, it's largely stretching and relief of spasticity and leg spasms and an upper body stretching done essentially in zero gravity.
Well, his endurance level is a lot better. His trunk strength is better. He's able to sit up properly in the wheelchair. He doesn't get fatigued as often. His hands are better since he's been doing the things that the OT is having him do. His outlook is better because he's happier.
If you're thinking about rehab, I would say start as early as possible and go as often as you could go. If I could go every week, I would.